Welcome to Endoscopy video. The purpose of this video is to demonstrate you a case of cancer of the head of the pancreas that obstructed the common bile duct and the proximal part of the duodenum. As you can see, the common bile duct is dilated and it contains sludge. At the distal part of the common bile duct, there is a hypoechoic area that corresponds to a pancreatic mass that invades both the duodenum and the distal part of the common bile duct. This area was not visible at the CT scan, neither to the MRI, and this case shows the importance of EUS in the investigation of patients with jaundice of unknown origin with proximal dilation of the bile ducts. So this mass was measuring about 2.5–3 centimeters. The next step is to take a few samples from this area. In this particular case, we did 3 passages with a 22 gauge Boston needle by doing fanning, that means by changing the direction of the needle and by pulling the stylet slowly. After 1 or 2 passes, we also try to use sanction. I work in the last 6 months with a cytologist who is on site and who evaluates the adequacy of the specimen, because in patients with pancreatic mass, sometimes there is fibrosis, sometimes there is necrosis, so I want to be certain that my material is sufficient for diagnosis, and sometimes we have, in most of the cases, we have direct diagnosis at the time of the procedure, which is also very important for the patient who is very worried about the result. Obviously, we have to wait for the immunohistology, but I think it's a very good advantage of ROSE, rapid on-site examination, to have an initial idea of the nature of the lesion. So here you see the needle entering inside the mass, making samples in different directions. Slowly, we try to avoid, obviously, big vessels like the portal vein, which is very close to the mass. Another issue that I would like to discuss, independently of this case, is that sometimes the pancreatic mass is not accessible for puncture. In that scenario, what we can do is to look if there are any lymph nodes that look malignant, or if there are any liver metastases that can be punctured, because sometimes you don't even need to puncture the mass, you can directly puncture the liver metastases. Another common question is whether we need to give prophylactic antibiotics. The answer is no, except if you puncture a cystic lesion where there is a high risk of infection. So in that case, you may administrate ciprofloxacin 500 milligrams twice per day for 3 days. Finally, a very important part of the EUS examination of a pancreas that has a tumor is to evaluate the invasion of vessels, and this is probably the most difficult task. I have one more video in my YouTube channel that illustrates the anatomy of the vessels, and that makes your report very, very complete. You have to evaluate the celiac artery, you have to evaluate the mesenteric artery, mesenteric vein, spleen vein, mostly, and obviously the portal vein. Finally, in cases where you puncture, you have ROSE, rapid on-site examination, and you don't have sufficient result, you may ask to change the needle, switch to another needle. For example, you may switch to a 25 gauge needle, which is theoretically more efficient for lesions with fibrosis, for example, for a patient with chronic pancreatitis, or in cases where you suspect autoimmune pancreatitis, you may ask for an histology needle or 19-gauge needle in order to have more material for processing. Here you see a small quantity of ascites near the liver, at the corner of the liver and the duodenum. This is probably a bad prognostic sign of advanced disease. Thank you very much for watching this video, and I hope you enjoy the rest of the channel.